Welcome to lecture 60 of iFocus Online. Today we have Dr. Vikas Mittal from LGI Institute, Ambala. So we'll be talking on Erythema Multiforme, toxic epidermal necrolysis, and Stevens-Johnson syndrome. He's a renowned cornea specialist. He did his fellowship in cornea and anterior segment surgery in El Prashad in 2005. He was the medical director of Sanjeevani Eye Care Ambala City for 11 years. He has founded LGI Institute with the state-of-art clinical facilities, clinical research, and training components. He also runs cornea course and a fellowship program. Welcome to iFocus, sir. Over to you.
Thank you so much, Ankita, and thank you so much, iFocus team, Dr. Honavar, for arranging these fantastic series. And I'm sure who all are, you all who are listening to this continuously, it will be of great use, I think. And that too in COVID time, आप लोगों को घर बैठे you are sitting at home and still you are, you have an access to all these fantastic programs. So I'm sure that you will have a long way to go. So for my topic is SJS. So I was just discussing with Ankita and Rolika that it's great that on Friday night you guys are here for SJS, which is comparatively appears to be a dry topic. So I'll try my level best to make it as much interesting and as much informative as I can. I'm primarily a clinician. So I as Ankita said, I'm basically a cornea surgeon trained from Erythema Multiforme, Hyderabad, and we do see a lot of surface and SJS definitely is. I'm quite passionate about this particular subject. So what I'm going to do in this next 45-50 minutes or so, I'll cover why, what, and how of SJS. Why we should know at all, why we should be sitting on Friday night and discussing SJS. So that will be the first part. Second component, what is SJS? What happens on a microscopic level and what happens on a what happens on a macroscopic level? What are the signs? What are the symptoms? What do we see in a patient? And third component would be how. How will we manage them? How do we manage them? So why, what, and how? Okay, so have you ever seen an SJS patient? So I was just thinking that you can just recollect if you have ever seen an SJS patient. If you have seen an SJS patient, then how does a patient look like? See, how does a patient look like? It depends. It depends that who's seeing it. Is it a dermatologist who's seeing it? Or is it a patient who's lying in ophthalmologist has been called as an ophthalmology referral, and ophthalmologist is going in ICU or BUN ICU or BUN unit, and there he's seeing that SJS patient? Or is it an ophthalmologist who's sitting in IOPD and patient is walking into the IOPD and then you're seeing it? So these will be a different perspective. The SJS patient, how it looks like, it depends how and what time we are seeing it and who's seeing it. Dr. Vinay Gupta, one of my friend who's in PGI Chandigarh, he's a fantastic dermatologist. He came for our ocular surface workshop that was exclusively on SJS, and he shared a lot of things what these people they do in their BUN unit, BUN ICU when they see these kind of patients. So what do they see? We asked them that, okay, what do you see there? So that's what he said, that he sees a lot of hemorrhagic crust. He sees mucous membrane involved, more than 2 mucous membrane involved. He sees a lot of these kind of rashes. Then he tries to make out which rash is this, whether this is like a bullseye lesion, like which has a erythema in the center, then pellar, then erythema around it, or these kind of lesion where this particular pallor is missing. So this he calls target lesion, and this is atypical target lesions, and these are generally present in Erythema Multiforme, and he told us that this is generally present in SJS or TEN. So this is how a dermatologist look at the patient, and that's what he does. Dr. Parul Gupta, she is also in PGI Chandigarh, and she's a very good cornea surgeon. She frequently gets these calls, this ophthalmology referral, and when she goes in ICU or BUN ICU, this how this sees patient like this. When she sees there's a swelling in the lids, epithelial defect, sometimes epithelial defect on the lids, this skin is peeling, you touch the skin and peels off, the whole epidermis goes away, and sometimes there's a lot of edema, a lot of hyperemia, These can, she has to do a lot of things, whatever she have to sit in on the bedside. You can see this on the bedside. Whatever intervention she has to do, she has to do on the bedside in the ICU. This is, you know, what the patient is looks like from the perspective of an ophthalmologist who's going in ICU. And you know, she has to do a few interventions until the patient becomes smiling. And when the patient walks into an IOPD, so I generally don't go in an ICU, so we rarely get a ophthalmology referral because we have a private different setup, and we see a lot of patients. And when patient comes to us, which is, you know, in a subacute or chronic phase, mostly patients are very photophobic, can't open the eye, it's very difficult to examine them. And you know, when if they can somehow open the eyes by instilling some Paracon drops or anything, there's an intense hyperemia, sometimes lid edema, and you know, these lid margins, these are really bad. In fact, it's not normal, right? It's some friction, some you know, you can see the cheesy material coming out of this meibomian glands. And sometimes this crusting, you can see this mucocutaneous junction, the lid margin is really bad. And sometimes you see the patient comes and he's, you know, totally bony dry eye, can't see anything. There are two people who are holding him, somehow coming very depressed. So this is how we generally see these kind of patients. So why we should know about it? This is a very good article, you know, by Sayan Basu. So what they did was, in LVPI, they compiled the data, 20 years old data, and they found what is the natural history of this particular disease. So this was when they saw the patient first, the upper row, when the cornea was, and they either was advice of intervention, they didn't follow up, or at that time there was not much that, you know, this lid margin MMG and so many things that we have now was not there. Many patients were advised some intervention, they couldn't follow up. And this is when they saw, after, you know, 5 years, 7 years, 8 years, 9 years, you can see this cornea has become like this cornea has become like this cornea. So over a period of time, they tend to get worsened. So there's a window of opportunity. So if you know that what is SJS, what it does, that you may think about making some intervention at this stage and prevent this eye to become something like this. So this patient who had this SJS, bad SJS, when we did this few intervention, and look at this, the patient was smiling, elated. So he saw, I remember that he was in this kind of phase for good 4-5 years. And when we, after the intervention or the final thing, he was so elated. He said that I can go to my job, I've rejoined, I can sit on the computer. So many things these patients, they can actually do if you know what is the main problem and you deal with that particular problem. And we are on the way, we'll see how we have to manage these patients. And these rough looking lid margins I had shown you, this can actually become smooth, you can see here. And even though bony dry eye patients that I shown you, even there also there is some hope. There is, although, you know, there are few keratoprostheses which last for 3 years, there are few for 2 years, 5 years, but at least there's a hope. So these kind of corneas, we need to pick them up early. It's like, you know, in retinopathy of prematurity, if you don't deal with your retina at the right time, that person can go blind. Similarly here also, once the person becomes, this eye becomes bony dry eye, there are very limited options that we have. So we must know it. So I'll just, you know, this is a story of this lady. You might need to increase the volume.
25 years की पहले तो मैं अपनी लाइफ अच्छी से जी रही थी, मैं पढ़ रही थी.
She was doing nursing
कर रही थी. तो नर्सिंग का दूसरा साल था मुझे अचानक ये बुखार चढ़ गया और ये छाती में प्रॉब्लम हो गई. फ्लॉक्सिन प्लस सेफेडाक्साइड दवाई ली थी, तो उससे से हुआ है.
So she got a rash, bad rash.
पहले तो मुझे शरीर में, खाली शरीर में था.
Most of her body was involved. It was TEN.
और आँखों में भी हो गया है. उन्होंने ट्रीटमेंट किया तो मेरी ये सारी चमड़ी उतर गई है, नाखून भी निकल गए हैं, ये बाल भी निकल गए हैं. तो ये सब तो धीरे-धीरे रिकवर हो गया है. उसके बाद में आँखों के लिए बहुत सारे.
So everything got recovered except eyes. Multiple consultations.
बोल रहे हैं कि इसका ये ट्रीटमेंट है, दवाई है, बाकी
correct diagnosis at the right time, correct intervention.
यहाँ पे सर्जरी हुई है तो उससे भी थोड़ा बेस्ट होने लगा है, इससे तो बेहतर है। जो मुझे पहले हुआ था मतलब उससे धीरे-धीरे रिकवर हो गया।
She actually had
मतलब मैं मुकम्मल मतलब परमानेंट इलाज करनी चाहती हूँ कि मेरी दवाई छूटनी चाहिए।
See, this lady actually had rejoined her nursing work, and she could rejoin it, and these patients are extremely grateful. And I know that these SJS patients, whenever they'll come, they'll bring some or the other sweets or small things, a token of love, regard, and there's a tremendous amount of satisfaction if you can deal with these kind of challenging cases. And the intervention, but when you do, the results are really amazing if done at a right time in a right patient. So this is SJS is a rare disease, no doubt about it, and is still not easily fully understood. So again, there's an opportunity that we can invest ourselves into it. It doesn't handicap only patient but the whole family, and it has a chronic course. As you see, patient has to move around here and there, and when the patient has SJS or TEN, everything recovers if he so ultimately he becomes deal with these patients for rest of their lives. Right intervention, right time can make a huge difference, as I said, not in his quality but all people around them. So that's why we should know it, that what all we can do about it. So why part is over. So why we should know about SJS. Next is what is happening at a microscopic level and what is happening at a macroscopic level. So this is actually it's like a burn. It's an immunogenic burn. So our own immune system has become it's targeting our own body, and this is a type 4 hypersensitivity disorder. And because it is like a burn, these patients, they get admitted in burn ICUs. Vinay sees these patients, and as I said, he differentiates. He's first of all, what he does is he makes his diagnosis, whether it's a SJS, TEN, or anything else. These maculopapular rash that he sees on the eyes, and then hemorrhagic crust, these are quite typical. And then he differentiates. There's other conditions of skin also. So this is basically dermatologist's perspective and his zone and his area where he has to diagnose and then work with intensivists and take care of it. What is happening in pandermal keratinocyte necrosis. So this is what is actually happening. So it's a severe immunologic dermatobulous condition, has a very high mortality rate, significant, and the patient who gets saved specifically from TEN, they have long-term morbidity. And what is happening at a microscopic level is keratinocytes are getting died off, and then epidermis sheds off, epidermal necrosis resulting in splitting in the subdermal layers. So what is more severe is TEN is more severe than SJS, and there is overlap also. So the Erythema Multiforme, this is a very mild disorder. So you can see it involves only 10% of less than 10% of the surface area. SJS and TEN, it involves more than 30% of surface area. And target lesions are present in these, and these are target lesions typical target lesions are present in EM, but atypical target lesions are present in SJS and TEN. So mortality, 1 in 100 patient may die in SJS, but 1 in 4 patient, or sometimes 2 in 4 patient may die in TEN. So mortality rate is high, need to diagnose early. So the patient has to present to an dermatologist or intensivist where he can be taken care of. Incidence, it's 1 in 10 lakh, fortunately quite rare. And this study where they found was whatever patient were admitted, 95%. So this was actually a tertiary care center. So overall population-based studies, approximately 1 in 10 lakh patients, 10 lakh people. Incidence, I have seen patient who was I think youngest I have seen is 2 years old child, and elderly also. We have seen patients who are 60 odd years, but mainly it's children and adolescents that we see SJS in. while TEN can occur in all the ages. And mortality from TEN, as I said, is twice as high in elderly, in 51% instead of 25% that we discussed just now. Offending medications, many, more than 200 medications have been reported in literature. But as sulfonamide antibiotics, anticonvulsants, I have seen many patients who have reaction to this phenytoin or anticonvulsants, and then NSAIDs are very notorious. And sometimes there is a cross reaction also. So, sometimes patient gets the same reaction, same drug reaction recurrent. So if he takes that, or in that group, same antibiotic of same group, he can get a recurrence as well. There are non-pharmaceutical triggers also. Virus, there are sometimes, patient says there is no drug reaction. You keep asking history, there is no drug reaction. It's the viral infection followed by the patient gets these body rashes and nails falls off, and then mucous membrane gets involved. Even natural remedies has been reported in the literature. The patient, what we have seen, the patient who has viral infection, they tend to have even poor prognosis when we deal with them as far as eye surgeon or ophthalmologist is concerned. It can affect oral cavity, respiratory, genitals, gastrointestinal, and it can you can see it can affect a lot of systems, mainly 2 or more mucosal membranes. It gets affected in SJS or TEN. SJS without skin involvement, yes, it is possible, but it is very, very, very rare. And generally, it represents mycoplasma associated. These are rare conditions. You just should know about it. This is what Dr. Vinay Gupta discussed when he was here for the workshop. So what we know now is a type 4 hypersensitivity reaction. There's an immunogenic burn, which is take more than 30% of the body area gets involved in TEN, around 10% in SJS, and then a 2 or more mucosal membrane also gets involved. This is what, and now how do we manage what is happening at the microscopic level, as I just said. So the patients are genetically predisposed. So there are population who are predisposed for a reaction in a particular drug. And this is, HLA specific. Many times, if one patient gets a hypersensitivity reaction to one particular drug, and it's diagnosed as SJS or TEN, their family members are consulted, because it's a possibility that one of the family member can also get that reaction. So these are genetic risk factors are there, and these are drug specific. Excessive and misdirected immune response, we have already discussed. This is how, this table tells us that how these CD4, CD8 T cells, the killer cells, these are causing these keratinocyte apoptosis as well as epidermal necrosis. So this is what is going on a microscopic level. All these killer cells, fast ligands, they are causing the damage of these epidermal cells. In eye, so you can recollect, this is anterior lamella of lid. These are muscle, and then eyelash, and posterior lamina. This is meibomian glands, and these are meibomian orifices, the line which separates gray line. So this area, the posterior lid margin, all this membrane, this is a non-keratinized epithelium. The whole thing, this mucosal membrane gets affected, and this is mucocutaneous junction where skin cells are just meeting the conjunctival cells. So keratinized is meeting non-keratinized. This is mucocutaneous junction, and this gets damaged in SJS. So that's why these skin cells, the keratinized epithelium, grows inside the posterior lid margin. So so you can see this is all the same thing that I've just shared with you. This is how we see hyperemia, photophobia. Sometimes, we see even epithelial defects. Epithelial defect is very difficult to manage when we see in SJS, and you can see even these kind of picture as well. Sometimes epithelial defect is, full thickness, all over cornea, and you can see the dry eye also, because this immunogenic or this inflammation it damages the lacrimal gland also. It causes dry eye. So dry eye, epithelial defect, you can see that. And sometimes patient can present as corneal melt as well. This is a patient who had limbal stem cell deficiency. This is a partial and total, because there's a dry eye, there's inflammation, there's mechanical rubbing. All these things can cause limbal stem cell deficiency, and ultimately the whole cornea can become really bad. We have already seen this is the meibomian gland, which gets really inflamed and all cheesy material inside. And this is actually these skin cells, the keratinized cells are growing inside. And this is the dead cells and the degeneration, which we can call keratin. So this is the keratinized epithelium. So if this posterior lid margins becomes rough, this is the area which is going to rub on the cornea, and that can cause a lot of scratches and slow and steady damaging the limbal epithelial cells. Sometimes this you can see these are the meibomian glands, and this is an SJS patient whose meibomian glands died off totally. So on a long-term basis, ultimately meibomian glands can die off as well. This is a bony keratinized surface. This is again a long-term, ultimately the patient can land up like this as well. So this is acute, subacute and chronic stages. As acute, we have already discussed, the patient can present as bilateral conjunctivitis, the way, when that is what we see when the ophthalmologist is called in ICU. And subacute stage, when the skin lesion has been resolved and is the ocular symptoms that are there. So it can be smoldering chronic cicatrizing conjunctivitis. We can have trichiasis, irregular lid margins, and mainly lid margins, which gets really bad. In chronic stage, there's persistent inflammation. You can see meibomian gland atrophy that I have just shown you photograph, cicatricial entropion, trichiasis, chronic dry eye, because the lacrimal glands gets destroyed, and then compromised ocular surface we have already discussed, and destruction of corneal limbal stem cells, and end stage will be a dry keratinized ocular surface. So this is how a patient of SJS presents in various stages. This is showing all these presentation in one particular photograph. So why we should know? Because we can do something about that. We can change the whole, we can contribute towards changing the whole life that they lead. What is happening on a microscopic level? Type 4 hypersensitivity. What are signs and symptoms? Depends whether it's an acute stage, subacute stage, or chronic stage. So now comes, how do we manage them? Again, this depends who's managing at what stage. A dermatologist generally is the first line who manages these patients. He, along with intensivist, these patients mainly, first of all, offending agent has to be stopped or removed, and management of all respiratory, wherever they have the disease has caused damage, and artificial membrane or biological dressings, all necrotic skin they generally debride. They ensure that there is no sepsis, because as I said, the mortality rate is quite high. And steroids, systemic steroids, although it's controversial, but most of the intensivists and dermatologists, they prefer using steroids so that this immune response can go down, but they have to keep an eye on the infection, the secondary infection. Then there are intravenous immune globulins, plasmapheresis. But again, this is the job of dermatologist or intensivist who are managing when the patient is presenting for the first time. When ophthalmologist goes in OR, so for ophthalmologist, there are windows of opportunities. So what are these windows of opportunities? This, I think this slide, you can take a screenshot also, but this is very important. When do we intervene? In acute stage, if there is ocular surface or eyelid margin epithelial defect. See, we'll have to, if there's an epithelial defect, that has to heal. We have to work hard on ensuring that epithelium gets healed. Because if epithelium doesn't get healed, ultimately the stroma can get, you can have collagenolisis, ultimately it can get melt away. Pseudomembrane formation, if we see pseudomembrane, again, that's a time when you have to do something. Chronic, if, as I just said, posterior lid margin gets irregular, or there is a lid margin keratinization, trichiasis, this trichiasis, it will keep on eroding cornea, it will keep on eroding limbal stem cells. Tear deficiency, dry eye will have so many problems. Persistent epithelial defect in SJS patient in chronic stage is really, really challenging, and we have to be patient and deal with this very aggressively. So if there's a window of opportunity, what is the intervention? In acute stage, protection of the denuded ocular surface. So if the ocular surface is deepithelialized, you have to protect it. Prevention of symblepharon formation. If there are two raw areas, it can get stick together. And reduction of the ocular surface inflammation. These are the goals of ocular therapy. So as I said, when an ophthalmologist goes into OR, the most important thing is do a amniotic membrane grafting. So whenever there is a raw area that needs to be covered with amniotic membrane, it is very difficult. You can't take the patient into OR. You have to do this intervention on the bedside also. And then you can see this, there can be rings, different kind of ways how we can do amniotic membrane grafting in these patients. But if you ensure that ocular surface inflammation goes down, you ensure that ocular surface gets epithelialized. When the patient goes out of one ICU, generally the eye gets healed pretty well. What we can do if there is no ocular involvement, just lubricants. If there's conjunctival hyperemia, you need to give some antibiotic as a prophylaxis. But again, prednisolone is very important. And if there is ocular surface or epithelial defect, if there's an epithelial defect, have to use amniotic membrane. And amniotic membrane, sometimes it's not that you do amniotic membrane once and it's over. You might have to do this amniotic membrane again, because this is an inflamed area and it's a biological tissue. This gets melts away. So sometimes even on third or fourth day, you might have to repeat amniotic membrane transplant. So this we have already discussed. We have to give steroids, antibiotic, chloramphenicol. I like chloramphenicol a lot because it's very surface friendly, and preservative free lubricants. So lubricants have to give 1 hourly. These will be preservative free. How we can place? Dr. Bhaskar Rai Chaudhary, he had shown amniocerter, where there is a small instrument through which the amniotic membrane can land into this ocular surface. Then you have Procera. Procera is nothing but this is a contact lens on which amniotic membrane is wrapped. And this video I have downloaded from Darren Gregory. Darren Gregory has a tremendous work in acute SJS. So this is what he's doing. You can see this skin is peeling off. This whole ocular surface is denuded. So there is no epithelium. So what he's trying to do is covering this amniotic membrane through and through. So from lid margin to lid margin, he will cover the amniotic membrane on the tarsal conjunctiva, fornicis, bulbar conjunctiva, and cornea, and from lower lid to upper lid. And then here what he's trying to do is ensuring that whatever adhesions are there, he'll separating these adhesions, and in that adhesion he'll place this amniotic membrane. And then you need to take fornix formation sutures. This is the bolster from inside out. You can see this is a routine fornix formation sutures, and you can see this amniotic membrane. So at the end of the once you have this whole thing from lid margin to lid margin, the whole thing is wrapped with amniotic membrane. So you need to place a symblepharon ring, and fornix formation sutures are also taken. So important thing is you have to do some other way. Either you use amniocerter, use Procera, you use this kind of thing, or you can make a ring on its own. The basic aim is to have amniotic membrane covering that denuded epithelium, so that if there are two raw areas, that will get merged, or that will get, there will be an adhesion. This will stay separate, and amniotic membrane per se has anti-inflammatory properties. So this can reduce the inflammation a lot, and it will improve the chances of epithelialization. So this is what we do when you are called in ICU. You give either lubricants or topical steroids or repeated AMG. So this will be our role when the patient ophthalmologist is called in ICU. So this is what the patient is if he's coming in subacute or chronic phase. When the patient is walking to IOPD, so that means his all rashes and all those things are resolved. So I'll come back to this table once again. So I'll just tell you my story. So I did my fellowship around 15 years back, 2005, 2006, and I used to be posted with Dr. Sangwan. And so there in those days, what we used to do is, so I knew that if the Dr. Sangwan will see these kind of patient, he'll give steroids, he'll give lubricants, and he'll see review back to the clinic. And if he sees these kind of things, so he'll ensure that the keratin is removed. We used to take a earbud or sponge, we used to remove this keratin and give lubricants, and if there is inflammation, steroids. And if we find these kind of things, I still remember we used to, in the OPD itself, we used to squeeze out all this secretion, ensure this meibomian glands become empty, and then remove this keratin, and then send the patient back. So what I understood when I came to my practices, it is a triad of dryness, mechanical issue, and inflammation. Dryness because lacrimal gland has been damaged, inflammation because there's an inflammation per se, and then mechanical, there's either trichiasis, lid margin irregular, entropion, these mechanical issues. So these are causing dryness, inflammation, mechanical issues are causing damage to the ocular surface. This is what is happening. Dryness we are taking care of by giving lubricants, inflammation by on and off steroids, and mechanical just keep on cleaning it, or if there is entropion, take help of oculoplastic surgeon and ensure that the entropion or trichiasis is taken care of. Then came this landmark paper from Geeta, Dr. Geeta Iyer from Shankar Netralaya, and she published her reports of lid margin MMG in SJS. So before that, I knew that lid margin MMG or mucous membrane grafting is done by oculoplastic surgeons, but I didn't know that lid margin MMG can make a huge difference. Then I went to LBPI, spent some time with my friend Sayan, and learned MMG. There I actually realized that a cornea surgeon must know the lid anatomy very well. As a matter of fact, any ophthalmologist must know it very well. So there only I realized that what is happening on the posterior lid margin is these cells, this mucocutaneous junction gets damaged, and these cells, the keratinase epithelium is growing inside. So this, we know that this is the posterior lid margins, this is the anterior lid margins, and this is the keratin. Keratin is nothing but these dead cells along with its degeneration. So if this mucocutaneous junction, this gets damaged, this is main barrier. So these cells will grow inside and will cover the posterior lid margins. So when the lid margin will cover the this rough thing will cover will blink, and there will be lid viper keratopathy or damage of cells. It is very important that fluorescence stain itself can tell us where is this mucocutaneous junction, and this is actually posterior to lid meibomian gland openings. And all these in this SJS, basically this lid margin gets attacked, and there's an inflammation, this barrier gets damaged, and these cells grow inside, and that's why we get this keratin on the posterior lid margins. You can see a different patient with that. And there are grading also, from low. It's very important to pick up these kind of, irregular lid margins and lid margin keratin. But sometimes you miss this. But this doesn't get missed if you stain well. And with stain, not only see the cornea, you see the lid margin as well. So as I just said, that if this lids, it will keep on rubbing, what will happen? So the cornea will be really bad. But so this particular area can be replaced by smooth epithelium from mucous membrane from the lips or oral mucosa, and this is what we call lid margin MMG. Dr. Geeta Iyer had come in that ocular workshop that I discussed, and she explained this whole thing in detail. And now after that, this paper and going to LBPI, I understood that when this comes to a mechanical thing, you can actually replace it with a lid margin MMG, and lid margin MMG has been a kind of revolution in the management of SJS patients, specifically in later the chronic stage or subacute stage. And important thing is you pick them up early, treat them early, the cornea can remain shining. So I'll just take you through this video how we do this lid margin MMG. So this is lady who had come in a chronic stage. You can see the cornea is pretty good. So this is an ideal time. You have to do this lid margin MMG. So first I'm taking is stay sutures. First incision is on the gray line. So idea is to remove this posterior lid margin, and this is all cells that we don't want. So this portion is removed. So gray line, and this is generally 30 mm by 5 mm. This whole thing is removed. I'm using the Vanna scissors. In between, I'm covering the cornea with the viscoelastic substance. Same thing we are doing on the lower lid. It is very important not to cut the tarsal plate. That is a key point. Now the lips, lip mucosa everted. This is 30 by 10 mm. So 30 by 5 will be for upper lid and 30 by 5 will be for lower lid. So again, this is harvested. You have to take care of a few things. Then we are dissecting this lip mucous membrane, mucosa, and this needs to be trimmed off. And the end point is when you can see these marking which are there on the epithelial sides. So this is divided into two parts. 30 by 5 will be on the upper lid and 30 by 5 will be on the lower lid. It is very important. What we learned was this mucous membrane should be within the well that has been created here. So this epithelium which was removed, it must not, it should be well within this particular well that has been created. So this is continuous interlocking sutures that we are taking. Only the anterior part is placed with the sutures. Posterior part, posterior edge will be placed just by using fibrin glue. So this is this sutures need not to be very tight. So there is no, there's no leak kind of thing. This graft stays flat on the tarsal plate. So our main aim is to wrap up that lid margin, the perpendicular lid margin, posterior lid margins with this particular mucosa. So these are interlocking sutures, and on the posteriorly, what I'm going to use is just fibrin glue, and this will lie flat on the posterior, on the tarsal plate. Whatever extra graft that is there, that I'm cutting, I'm making sure that there is no overlap, because if there is overlap, the conjunctival epithelium grows inside, then there can be a necrosis. Same steps are used for the lower lid margin. Continuous interlocking sutures. Anterior margin is sutured. Posterior margin is secured with the fibrin glue. Excess of graft is removed. And the cornea is covered with the viscoelastic substance. It can be easily done by a cornea surgeon, and although oculoplastic surgeons has been doing it for quite long. So this is the same patient, first postoperative day. You can see within 2 weeks, and this graft gets taken up within 4 to 5 days, because these blood vessels, they connect with the mucosal of oral mucosa very well. And this is, I think, 2 weeks, and within 1 month, you can remove these sutures after 1 to 2 weeks, and the irregular lid margins becomes pretty smooth. The other patient, you can see this is a rough with keratinized posterior lid margin, and very smooth, covered with the mucous membrane. So we saw that we just compiled our results, and we found that 94% there's a successful uptake. So success rate of lid margin MMG is very high. There is definitely some learning curve, but once you learn it, it is generally highly successful, and patients are very comfortable even on right from day one. So this patient had necrosis. Again, these are learning curves, that is possible. So 94% were uptake. There can be some problem also, but with time you learn all these things. So overall, the dryness can be taken care of by lubricants, inflammation can be taken care of by steroids, and mechanical by lid margin MMG. Second very important thing that has happened in last decade or so is frequent use of scleral lenses. Scleral lenses also ensure the posterior lid margins or lashes, they don't touch the ocular surface. And we do counsel our patient of MMG that we might need to give scleral lenses as well. So this patient was actually underwent lid margin MMG followed by scleral lens. The scleral lens not only makes the patient comfortable, this also helps in improving the vision even in the presence of some corneal scar. So in case you see any patient when you are treating, whether it's a subacute stage or the chronic stage, epithelial defect needs to be taken care of with amniotic membrane grafting. And in case you have a corneal melt, again, why does corneal melt happen? If there's a epithelial defect, it remains, it becomes persistent epithelial defect. It causes collagen lysis and there's a melt. So when you saw the epithelial defect on first time, there itself you have to be aggressive, give lots of lubricants, BCL. If doesn't work, AMG, multi-layered AMG. If still patient happens to land up with corneal perforation, then you can do a tenon patch graft or cyanoacrylate glue if the perforation is small. So this patient had undergone actually a tenon patch graft and did pretty well. So again, tenon patch graft, use of multiple modalities we use when we are dealing with these kind of patients. And if you have this kind of thing, there is total limbal stem cell deficiency, a daily glaucoma, you can see here. If the eye is wet, then you can do type 1 keratoprosthesis also. So this patient was underwent endoscopic diagnostic endoscopy to see how the posterior segment, and then underwent type 1 keratoprosthesis. Again, it is not a simple thing to do keratoprosthesis. It is very, very challenging in SJS patients. And sometimes this keratoprosthesis doesn't last even for 2 years, 3 years. But if at least we have a modality that can be offered, and if it doesn't work, then you can think about doing OKP or other keratoprosthesis. So this lady, this is a patient from Dr. Sangwan. This patient had a bony dry surface and underwent LVP K-Pro, which is a modified type 2 keratoprosthesis. So you should know at least this thing, that there is something for bony dry surface as well. There is something for end stage as well. So again, this is the final table that we have discussed. This covers up most of the things what we are going to do. So I'll end with this lady which I saw in today in the clinics. She had this bad SJS, and this is how her ocular surface looks like. Isn't it beautiful? So we generally wish and pray that all our SJS patients land up something like this. And if you do intervention at the right time, there's a possibility that you'll be able to save a lot of these eyes. I have these are two very good articles, review articles, which I have used. I've used tables from these particular articles, and I acknowledge the efforts of my fellows, Dr. Indrajot Kaur and Dr. Yatri. This was when we had ocular surface workshop. Darren Gregory, Dr. Jim Chidosh from Harvard, Dr. Sangwan, Dr. Urvish does a lot of MMG at our place. Dr. Swati is an oculoplasty surgeon. My colleague, Dr. Pruasha. And in case you want to dig in deep, you want to know more about it, the whole meeting, its detail is already available on the YouTube. And I would like to thank again Dr. Sangwan and Dr. Jim Chidosh, fantastic ocular surface surgeon with a great knowledge about ocular surface diseases. At the end, in case you are thinking about doing a fellowship, so there are some good videos where there are experience of all the great surgeons all over India, and you can go through these videos if you want. Thanks so much. I'm willing to take questions if there are any.
Thank you so much, sir, for such an awesome talk with such a beautiful pictures, results, and the videos, and especially your tables. So informative. And yeah, something new which students will be knowing now is afteropthal.com. Something really interesting and new, sir. So we'll go ahead with the question, sir.
Sure.
Yeah. So the first question is, are ocular findings always related with a systemic manifestation in these cases?
Not necessary, but yes, if the patient had 10, which means it was extensive, they tend to have more ocular disease. What is important is how well the patient was managed in acute phase. Suppose the photograph that I had shown you a small child, if suppose there was no ocular intervention, suppose there was no AMG done, nothing, So ultimately that might have landed up into, really bad or even a bony dry surface. So what is important is how it was managed during the acute phase. That is going to change the whole course of the disease. Ocular manifestation are more in TEN than in SJS. That's true.
Yes, so the next question is when we talk of SJS and TEN, regarding in terms of treatment and prognosis, what is the difference?
TEN, as I said, the mortality rate is very high. So TEN, 1 in 4 patients, they die. So mortality is very high. And from ocular point of view, when the patient is coming into ophthalmic OPD, then it hardly matters. You have to deal with what is remaining in the eye. Because as I said, the patient will ultimately become a patient of ophthalmologist, right? So that intensivist, dermatologist, that role has gone. So whether the patient had, so when we see patients, it hardly matters whether the patient had SJS or TEN. We just see what is there in the eye and we deal with them. As I said, that if the patient had a viral disease, those they tend to have poor prognosis. So we just keep that thing in mind, that how bad it was, so what could be the prognosis. But ultimately we deal with what is present. How much is the dryness, how much is the inflammation, how much is the mechanical damage. So we just deal with 3 things when the patient is coming to the ophthalmic OPD.
Okay, so the next is when we are using MMG. So how do we decide on the size of the MMG graft which we take for these patients?
So we, as I just showed you in the video, what we generally do is we have to cover the central two-third, because that is the area which is going to rub on the cornea. So what we generally do is we take a larger one, 30 millimeter by 5 millimeter. Even if the keratin is more, we just remove that keratin, but we don't take a bigger graft because that is not needed. So we need to wrap up this posterior lid margin, which is going to touch the cornea. So we generally remove the puncta. We just cover the puncta also, because these patients, they do very well with small punctal cautery also. Suppose everything is fine, your puncta are open, you just do a cauterization. So while doing MMG, what we do is we cover the puncta also. So you need to take the same graft size, 30 by 5 in all the cases. 30, actually it becomes 25 or so, 25 by 5 in all the cases, irrespective of how much the keratin is. So it's not that if the breadth of the keratin is more, so I'll take larger graft. No, so it will still the same central one only.
Okay,
does that answer it?
Yes, sir. The other question related to it is, when we are taking MMG graft, when we are preparing the graft, what all precautions should we take? Like, is it like whatever the how deep should we go, and what all tissues should be removed, or should we check that it should not be grafted, or is it like everything should get?
Yeah, true. So idea is to basically, we want to take epithelium, right? So down there lies the muscle. So we need to spare the muscles. So what we need to take is epithelium and maybe some adipose tissue. That's it. So we must not go very deep. We need to spare the muscle. And when it comes, again, you have to thin it down. The thinner it is, the better it is. In all ways. So what is that thinner? We need to remove those adipose tissues. So what will remain is just epithelium and some fibrous tissue. That is what we are going to transplant.
Okay, sir. And in terms of amniotic membrane graft, is there any difference when we are using the fresh amniotic membrane graft or the dry commercial ones?
Okay, so I had an experience with dry amniotic membrane grafting. Somehow I didn't like it. The reason is, when this is a dry and you have to instill BSS for some time, and then it becomes swollen, and then you transplant it. So what I found is it's quite thick and it doesn't stay. It doesn't stick with the fibrin glue. So in case you're using dry, you'll have to suture it. And I had an opportunity of doing it in 2 or 3 occasions, but I didn't like it. So what I feel is the wet AMG, wet amniotic membrane, that graft is much better because thin and can stick with the fibrin glue pretty well.
Okay, sir. And okay, the next question is somewhat related to the dermatological part, that in terms of acquired ichthyosis and SJS, when we talk about skin peeling, is it different in both the condition, or is it similar? Or how to differentiate?
See, I don't think I have an experience in that. I am not very sure that how does it work. But the peeling is what dermatologists tell us. I have personally seen 4 or 5 such cases only, because as I said, I don't have an exposure to go in a ophthalmic OPD. So whatever knowledge we have is from the dermatologist. So that's what they generally say. There was a table over there, so maybe you can take a screenshot of.
Okay, sir. You showed a table where we had the where acute stage, subacute, and chronic stage was given, sir. So in acute stage, it's generally they present as conjunctivitis. So what are the red flag signs or the initial signs, when we should be aware that, okay, it can be SJS, it's not just a plain conjunctivitis?
Okay, so see, SJS, you will not see SJS only nice. So SJS means there will be skin. As I said, 10 to 30% of the skin area will be involved. Skin peeling will be there. At least 2 mucous membrane will be involved. There will be oral mucosa will be involved. There is possible nasal mucosa might be involved. Eye mucosa, genital mucosa. So if there are more than 2 mucosal involvement, around 20-30% of skin area is involved, skin rashes are there, then only you will call it SJS. Just by seeing eyes, you will not call it SJS. SJS only in eyes, I have seen a couple of patients, but I think that's very rare, and we were not sure that actually that is SJS. SJS we'll call only when there is skin involvement, where there is mucosal involvement. But red flag sign, I think that there's an important thing over there is, in case you are seeing an acute patient, acute SJS patient, what you must see, you must do a fluorescein stain, and take some blue light with you, do fluorescein stain, and if there's an epithelial defect, that's a red flag. That means you have to intervene. You have to take care of it.
Okay, sir. There are many centers who says that they don't have AMG. So is there any substitute which we can use for the surface?
At the moment, in case you don't have, then you can try dry amniotic membrane. But see, if you just be a bit proactive, there are many centers, many good centers which can supply you AMG. So procuring an amniotic graft should not be a problem. It's just that you need some proactivity. Try to search which are the areas which can provide, which are the centers which can provide you amniotic membrane, or maybe you can tie up with someone. But if you want to really do it, it will need some proactivity.
Okay, sir. And how to differentiate between the keratinized lid margin and keratinization on the lid margin, which is seen because of squamous cell carcinoma or the sebaceous gland carcinoma?
Sebaceous gland carcinoma, there will be a carcinoma over there. No? There will be a lesion, which will be a neoplastic lesion you will be seeing. Lid margin keratinization, that there will be a history. Either there'll be as I said, SJS, or sometimes long-term surface toxic medication that can also cause lid margin keratinization. It will be more or less smooth. So the first sign that you are going to see is irregularity of posterior lid margin, or shifting of that mucocutaneous junction, and then you'll see this keratin. Keratin per se, if you want to see just keratin will be same, whether it's due to anything. So if you stain with the fluorescein will not stay there. It will keep rushing off. So that is an area of keratin. Or in case you want to see with the rose bengal, you can see with rose bengal as well. So whether that keratin is, why that has happened, so that depends. You'll have to see other associated thing, whether there's a lesion over there, there's a neoplastic lesion over there, or there's a history of SCS, there's a history of rashes, there's a history of surface toxic medications, and all those things.
Okay, sir. Is it always that whenever there is a keratin membrane formation over the lid margin, we should always debride it?
No, see, keratin membrane. So what I had photographed. So again, keratin is dead cells and it's degenerated material. That is keratin. So in case you somehow, you can't do an MMG, or you can't do a surgical intervention at that time, what you can do is, for some time you can remove it with a surgical sponge or bud. Ensure that whatever degenerated epithelium you can remove, you should remove. And you can use a scleral lens also in the meantime, in case you have to wait for any surgical intervention in the form of lid margin MMG. The membrane, I don't think if you want to, if you are referring to the membrane that we see in acute stages. So if you are referring to that, yes, then that all those membrane, those pseudomembrane, those are pseudomembrane that has to be removed, and that should be covered with amniotic membrane.
Okay, sir. And so how and when to decide whether we should go ahead with the topical steroids, and if steroids has to be used, should it be like low potency or a higher potency steroid? How we decide on that?
Okay, so if there is a surface inflammation, you have to use steroids. Steroids, there is no point in using a low potency steroid. What we generally do is we use prednisolone or dexamethasone. In chronic diseases where you have smoldering inflammation, very subtle inflammation, there you can use low potency, maybe loteprednol or chloromethylone. But in acute stage, you have to use prednisolone 40. There's no point in beating around the bush. Again, in case subacute phases where there's intense hyperemia and it is causing an issue, then there again you'll have to use prednisolone. Low dose, low potency steroids only when there is a very light in a chronic stage on those cases.
Okay, so in surface with inflammation and corneal epithelial defect, should we give steroids or should we wait?
So if there is an epithelial defect that needs to be addressed, means what? That you should do an amniotic membrane or use a bandage contact lens, may consider tarsorrhaphy. If there is a surface inflammation also, you can wait. You can wait for steroids. Because why in these cases there will be a chances of secondary infection as well. So you need to be really balanced. If you are experienced enough, like we do use steroids a lot, even in these epithelial defect, but we keep a watch on if there is any we ensure that we give a prophylactic antibiotic as well. So I would suggest, in case you have a doubt, don't use steroids. Ensure that your epithelial defect gets healed by AMG, tarsorrhaphy, BCL, frequent lubrication, whatever. And once the epithelial defect is healed, then you go ahead and give steroids. The condition where there is an epithelial defect and still steroids can be given easily without thinking anything is chemical burns or chemical injuries. So there you don't think about anything. So if there's an epithelial defect or not, the first 2 to 3 weeks you have to give steroids.
And how long should we wait before initiating steroids in these patients? Sometimes there are cases where the epithelial defect, despite of using the measures or despite for waiting for 1 to 2 weeks, does not get healed and the surface is also inflamed. So any role of immunomodulators that we can use in them, sir?
Yes, in some cases, what happens is, although this is a very small subset of patients, where when we are dealing with subacute or chronic, so there's dryness, mild, and this inflammation, per se inflammation, is coming in and again. So you need to understand that if there's an inflammation, what is the cause? Is it because of bad lid margins? Is it because of prechiasis, endopium that is causing an inflammation, or the disease per se is causing an inflammation? If so, yes, there's a small subset of patient where we have to give systemic immunosuppression as well. So we see a lot of SJS patients, but they're very few. I would say less than 10% of patients they are on systemic immunosuppression, like either azuran or methotrexate or a combination. So there's a very small subset, yes, where there is a recurrent inflammation, there you have to use. Again, you have to understand, you have to be sure that why this inflammation is there. So it's not that just a mechanical issue that is causing an inflammation. It's a disease per se. Inside that there's an inflammation. There you have to give some systemic immunosuppression.
Okay, sir. The next question is, once we use my MMG, what are the chances of recurrence?
Chances of recurrence of keratin, that's what I understand the question is.
Yes, sir.
Right? So chances are close to nil. If why we have seen, as I said, that 94% patient was normal, but in 6% there was a recurrence. Whenever there is a recurrence, that means there was some issue with the surgery. Either that graft size was more, it was overlapping the conjunctival epithelium. Conjunctival epithelium came inside, and these blood vessels couldn't reach the mucosal those vessel forms. Right? So there was no connection. That's why it was shed off. There was necrosis. Or there's a buttonhole. Suppose there's a buttonhole in that particular area, again, underline that will come up, and there you can have a small patch of keratin in your lid margin cases. But if your lid margin MMG is done well, nothing happens. The second condition where there can be some issue after lid margin MMGs, if the surface is very dry, in those cases we are very dry, there we do see, some recurrence of keratin. But most of them, they do pretty well, and there's unless if your surgery is nice, you don't get a recurrence.
Okay, sir. Is there any specific lubricant which you will prefer in these patients, sir?
So I like preservative-free lubricants, and because this is not that you can give it for 4 times, 5 times. So these patients, they require lubricants sometimes 1 hourly, sometimes even half hourly. So we give preservative-free lubricants, CMC, whatever you like. So what we generally do is sometimes, there is a tachyphylaxis with lubrication. So you change it after some time. So what we generally do is keep on giving CMC after some time. You change with hyaluronic acid, or, just keep on shuffling here and there. But what I like is 1% CMC is something I like a lot for these patients.
Okay, sir. The next is, in microperforation, how do we use glue? And should the steroid be continued at this time?
Very important question. Thanks for asking that. So if there's a perforation, again, you should know why this perforation has happened. Why did it occur at all? So if there was an epithelial defect, not healing, collagen lysis, melt. That was the cause. Second, there was an epithelial defect, not healing, secondary infection, and then melt. So these are 2 different scenarios. So if you have a persistent epithelial defect that led to collagen lysis and perforation, and the perforation is less than 2 millimeter, very small, just use a cyanoacrylate glue, and they do well, because cyanoacrylate glue will attract the vessels also, which will be good for these corneas. If there is slightly bigger perforation, you can use tenon patch graft, tenon patch graft or multi-layered AMG. There you can use and cover it well. If still bigger, then you will have to use either corneal patch graft, lamellar patch graft, of these things. Whether you'll use steroids or not, yes, if you have used AMG or you have used tenon patch graft, TABCL, you can use steroids if you want to continue because of the inflammation, provided this was not infection. As I said, if it is infection, that's a different ball game. You need to focus exclusively on infection, nothing else. You have to ensure, and these patients sometimes, they have gram-positive cocci, sometimes they have even candida. So you need to deal with those infections. So there you use preferably only cyanoacrylate glue. Don't use amniotic membrane, don't use even tenon patch graft, because those are biological tissues. The bacteria or whatever bug is there, that eats away that, the tenon patch graft or AMG as well. So infection, use cyanoacrylate glue, don't use steroids. No infection, persistent epithelial defect led to collagen lysis, TABCL or tenon patch graft or multi-layered AMG, can use steroids if inflammation is an issue.
Very informative and home-taking points, sir. One of the hot seater participant is raising hand. Dr. Ajiva, you can go ahead and ask the question.
Sir, can you hear me, ma'am?
Yes, you're audible.
I hear you. Please go ahead.
Sir, what is the difference between Erythema Multiforme and SJS, sir, when it is both is less than 10% involvement?
Erythema multiforme generally involves sometimes only one mucosa layer. Erythema multiforme is very mild, and they are generally secondary to either mycoplasma or HSV. So these are not typical drug reactions, right? And these are very mild. They do well. These patients, they do very well. SGS is like, although there is 10% of body area involved, but there will be 2 mucosal membrane involvement, right? And these tend to be more so. There will be a specific history of a drug reaction. So in erythema multiforme, these are not drug reactions. These are secondary to either mycoplasma or HSV or any other viral conditions. And you see typical target lesions in erythema multiforme. Those typical target lesions that I had shown you, those typical target lesions are not seen in SJS. In SJS, so there will be only 2 zones. In erythema multiforme, there will be 3 zones.
So one more doubt is, if the oral mucosa is involved, then how can MMG be done from the lip mucosa, sir?
Thank you so much for asking that fantastic question, Ziba. I didn't cover it. And see, very important point. So what we generally do is, if we see patient in subacute stage, means skin has resolved, nails have come, rest of everything is better, and now his main issue is eye. So at that time, we need to see how much inflamed the oral mucosa is. If the oral mucosa is inflamed, which is the case generally in subacute cases, you need to wait. You need to wait, let this thing settle, let this inflammation go away, then only take up. Because if you take the graft during where there's an active inflammation in the lips, in this oral mucosa, it will be very difficult. You'll buttonhole, and it will bleed a lot. It will be very difficult. So what we have seen, those patients, we generally wait. If we discuss with the patient's dermatologist or intensivist, if they are giving some immunosuppressant or still, we continue that, let it settle down, and then take when the inflammation is settled. Sometimes in the meantime, what we do is we use scleral lens. We see if there's a lid margin is bad, this keratin, it will keep on rubbing the cornea. So during that window period, say 1 month, 2 months time, at that time we use scleral lens, so that at least our ocular surface remains protected from the bad lids. Does that answer your question, Aziba?
Yes, sir. Thank you, sir. Thank you so much.
Thank you so much for asking that.
Thank you so much,
Thank
sir,
you, sir.
for answering all the questions so patiently and so nicely.
No, it's an honor. It's a pleasure. Thank you so much. Hello, Dr. Nawar. I can see you.
Hi. Very nice talk, Vikas. Wonderful.
Thank you so much for organizing it, and thank you so much for giving it an opportunity to
Pleasure.
interact with everyone. I was telling Ankita on Friday weekend night, and on a week.
In India, Friday is never a weekend. Anyway, great that you spent your Christmas evening with us. Thank you so much. Wonderful
Thank
talk.
you.
Very informative. Very interactive.
Thank you so much. Our whole iFocus team, Center for Sight, Dr. Nawar, Ankita, Mitika, Radhika, everyone. Thanks so much for this opportunity.
Thank you.
See you soon.
Good
Thanks.
night.
Good night.